Coronavirus Infectious Disease 19, a clinical case. So in this session, we're going to look at a clinical scenario with a case presentation and use that to examine distinguishing features which may help us to differentiate infection by SARS coronavirus 2, the cause of COVID-19, versus other respiratory infections currently circulating in the world, those being influenza A or B, parainfluenza, rhinovirus, and even some other typical pneumonias. At the end of the presentation, we'll also look at what factors precipitate a risk of progression. We'll start with our case, Mr. Lecturio, of course. This is his history of present illness. He is a 62-year-old male who comes to us in clinic with fever, cough, and malaise for 3 days. Importantly, he 2 weeks ago was evacuated from a cruise ship which was approaching Venice, Italy, due to a cluster of cases occurring in that part of that country. However, after arrival back in the States, he was fine until just 3 days ago and then presented with these symptoms. The fever is tactile. He's not measured it. However, the cough is dry, non-productive, and he denies any associated chest pain or certainly shortness of breath. The malaise, very typical flu-like illness, so tired, somewhat decreased appetite, just sort of moping around feeling not very well. The major features we should notice here are, number one, his age and the fact that he is a he. He's male. These are risk factors already emerging in COVID-19 as potentially suggesting more severe or advanced disease. He's had his illness for 3 days, not weeks, but 3 days. But he also had 2 weeks ago an exposure to a known source of COVID-19 disease via this cruise ship, and especially the country Italy. However, as we look at other infectious disease processes, simply being on a cruise ship, simply being on vacation, are all going to increase risk for other respiratory viral pathogens. So none of these are specifically going to delineate COVID-19 as the causative disease here. The tactile fever, the cough, which is dry, but no chest pain or shortness of breath, these are all very likely early presentation signs and symptoms for any viral process, as is the decreased appetite and the flu-like process. Review systems for Mr. Lecturio. He denies a whole bunch of things, so really no upper respiratory tract signs or symptoms like rhinorrhea or congestion. He denies signs of cardiac dysfunction, so no chest pain, palpitations, dizziness, or sweating. He denies prominent GI symptoms, so no nausea, vomiting, or diarrhea, or no abdominal pain. No rashes to suggest sort of a viral exanthem, which might go with other types of viruses, and no confusion or hallucinations, which could go along with, if not viral illness, potentially other psychiatric disorders or even encephalitides or encephalopathy. And then no decreased urine output. He denies urine changes, which argues against end organ dysfunction so far. However, he does endorse headache, a diffuse non-specific headache, and diffuse myalgias and polyarthralgias. Past medical history, he does have hypertension, which is ostensibly controlled with losartan, which is an angiotensin II receptor antagonist. He also recently has been diagnosed with type 2 non-insulin-dependent diabetes mellitus, which he claims has been controlled with diet. Social history, he's a certified public accountant, married with 2 children, 2 adult children. He had the travel, as recently noted, and no other known sick contacts or exposures such as unusual animals or pets or anything like that. Family history, also there are primary family members with hypertension, coronary artery disease, and insulin-dependent diabetes mellitus. So again, what leaps out at us from this additional history is that Mr. Lecturio has 2 additional comorbidities, that being hypertension, being treated with losartan, and a diabetes mellitus. The certified public accountant, yes, this might be a high-stress position. We're worried about it more because it means he has extensive face-to-face contact with a number of his clients, which means rather than having no sick contact exposures, he has potential for sick contacts. Again, that travel history, he had significant potential travel exposure from the cruise ship and also that part of the world where there is known COVID-19 circulating, as well as other respiratory viruses. And then the family history, again, significant 4 comorbidities which we know are associated with worse disease or progression of disease with COVID-19. Physical examination for Mr. Lecturio. So he indeed is febrile with a temperature of 38.6 degrees Celsius. He is somewhat tachycardic with a heart rate of 98 and tachypnic with a respiratory rate of 22. His blood pressure, maybe not as well controlled as he thinks it is, with the losartan is elevated at 143/92. The rest of his exam, however, at this point is normal. This, by the way, is very typical for early onset COVID-19 patients as well as other viral respiratory and upper or lower respiratory tract infection patients. So not much to speak of, including the chest exam, in which his lungs are cleared auscultation with good air entry throughout. So where are we at? Initial assessment. He does have risk factors which should make us think of higher risk for developing COVID-19 disease as well as progression to severe disease. However, his presentation at this point is still very much non-specific. It could be anything and everything. Similarly, his physical examination does not lead us in any one specific way. So what is our differential diagnosis? Well, of course, COVID-19 presenting with mild upper respiratory tract infections and potentially progressing, but not yet so far. Influenza, we know, can start with a flu-like illness, as noted, so fevers, myalgias, polyarthralgias, general malaise, and this could be all that he feels with influenza, or it could progress. Parainfluenza, typically a cause of croup in younger children, but certainly a cause of a staccato, dry cough with respiratory distress in adults who experience it, and with a very prolonged clinical course. Early onset symptoms, however, with parainfluenza, just like the first two I've already discussed, can be very nonspecific: fevers, malaise, dry cough. Similarly, rhinovirus. We all know about the 3 days coming, 3 days with us, 3 days leaving history of the common cold. The cough would be a little bit unusual for rhinovirus unless he's having postnasal drip. Similarly, the malaise, although if he's having a man cold, he could be experiencing that. So this could still be rhinovirus, which just is a little bit more overt in its presentation. And then other possibilities, bacterial pneumonias such as atypical pneumonia, perhaps caused by Mycoplasma pneumoniae or Chlamydia pneumoniae, or even some other unusual possibilities, Legionella, for example, all acquired via his cruise ship exposure or face-to-face contact because of his employment, his work. So what do we do next? At this stage, does he deserve further evaluation? Does he deserve further intervention? And at least from the COVID-19 response, the answer is no. He has mild disease, he's in no distress, he does have risk factors, but given the current shortage of testing kits in many parts of the world, it would not be possible, I should say, to do formal testing for COVID-19 because the ability with limited testing kits is somewhat reduced. However, it would be reasonable to consider testing for the other viral possibilities. So a nasopharyngeal or oropharyngeal swab to send for rapid assessment for influenza A, perhaps other respiratory pathogens on a panel. And then let him go home, shelter at home, self-quarantine, watch, wait, and see what develops. I will note, however, we have one critical lapse in our initial evaluation, and that is a spot check of his peripheral oxygenation, assessing his SpO2, which, if it were less than 93%, would be a strong suggestion of concern for progression in COVID-19 and might tip us into admitting him or at least sending him for further evaluation. However, we don't have that, so at this point, Mr. Lecturio goes home.